بسم الله الرحمن الرحيم. نفتتح الجلسة الرابعة ونطلب من السادة الحضور يعني التواجد في القاعة، ونبارك للدكتور يوسف المصري على المؤتمر الرائع الجميل اللي يعني جامع كل الأحبة، وإلى مزيد من التوفيق والنجاح. ويسعدني ويشرفني تقديم البروفيسور رشا طريف، الهيد اوف بيدياتريك اندوكراينولوجي اند اوبستي يونت عين شمس يونيفرسيتي. هتكلمنا عن ذا ريسبيراتوري فيس اوف اندوكراين ديس اوردرز. اوعدكم ان انتوا هتسمعوا محاضره اكثر من رائعه.
كده صوتي مساء الخير على حضراتكم. بشكرك على التقديم الجميل يا دكتور محمد، وحظي جميل بالتشير بيرسونز كلهم الحقيقه، يعني نخبه هايلي سيلكتد الحقيقه. وبشكر الاخ العزيز جدا على قلبي الاستاذ دكتور يوسف المصري على الدعوه، ويعني دمياط بلد جميله وانا سعيده بوجودي معاكم حقيقي. الواحد حاسس ان هو كده في بيته، يعني كرم فعلا وذوق ووقت جميل وفرصه اننا نتقابل ونشوف بعض. حيث بقى ان دكتور يوسف عنده لمب قوي جدا في الاي ان تي، حبيت الاقي لها ريليشن بالاندوكرينولوجي، وعشان كده المحاضره بتلخص الاي ان تي and the respiratory phase of endocrine disorders. خليني اقول لحضراتكم انه الاندوكراين system is a highly complicated system and it's not that simple as it might appear. It's like a puzzle. We need to fit the pieces of the puzzle together to reach a diagnosis and management. And from here comes the link between ENT and endocrine or respiratory system, because both of them are closely interconnected زي ما هوري لحضراتكم حالا في الدقايق اللي جايه. Hormones play an important role in controlling physiological mechanisms of respiration, including the ENT system. And in this box, you can see endocrinal regulation of respiration, which is either central, peripheral, or indirect factors like acid-base balance, temperature, and adipose mass. And the actions of hormones on respiratory system could be either stimulatory or inhibitory. For example, some hormones, by acting on the airways, induce bronchodilation like epinephrine. Others induce bronchoconstriction like histamine. Now, let me take you through a zoom into the endocrine system, and I'm going to show you some cases that presented with respiratory or ENT manifestations, and it turned out to be endocrine disorders. This is a 6-year-old boy presented to the ICU with disturbed level of consciousness, preceded by headache, vomiting, and blurring of vision. The boy had severe tachypnea and he was misdiagnosed as pneumonia, but actually it wasn't a chest condition. He also had acetone breath, polyuria polydipsia since 3 weeks, no family history of diabetes, his BMI is normal, no acanthosis nigricans, and in the ICU, when they did the hemoglobin A1C, it was very high, and the C-peptide was very low. The fasting and 2-hour postprandial blood sugar was very high, and he was proved to have acidosis, ketonuria, and electrolytes were normal, and the islet cell and GAD antibodies were high. So this is the CT brain showing brain edema, as you see. And what's your diagnosis? Yes, this is type 1 diabetes presenting with diabetic ketoacidosis. He apparently came with tachypnea, but it turned out to be acidotic breathing. So DKA may present with respiratory distress, and the initial presentation could be tachypnea. And please remember, DKA can present with deceiving respiratory manifestations. Apparent tachypnea can be DKA. And here you can see diabetes can present with various respiratory symptoms. Diabetics are more liable to bronchospasm, nasal allergy, recurrent infections, cystic fibrosis, obstructive sleep apnea. So indeed, there is a link between diabetes and chest and ENT. So I think it's really important to be careful when diagnosing and managing DKA, because the symptoms could be deceiving, like the boy that I showed you. And this is another 10-year-old boy. He presented with tall stature and considerable weight gain. الأهل قالوا إنه بيطول بسرعة جدا جدا، بيغير مقاسات الشوز، وكف إيده وكف رجله أكبر من إيدين باباه، مع إن عنده 10 years old. وزي ما حضراتكم شايفين حصل separation of the teeth لأن الماندبل عمال بيكبر. Progressive increase in the size of hand and feet, the shoe size. He is very tall and the BMI is high. Separation of the teeth, macroglossia, hoarse voice, obstructive sleep apnea, and nasal polyps. He also had bronchospasm and recurrent chest infection. He was in tenor stage 1. He also had headache. His basal growth hormone was very high, and he failed growth hormone suppression test. And serum IGF-1 was very high as well. Other pituitary hormones and prolactin were normal, and the bone age was advanced 1.5 years. MRI celatosica showed pituitary adenoma. How does growth hormone adversely affect the respiratory system? You can see in this box. First of all, growth hormone triggers thromboembolic manifestations. It can be a cause of laryngeal hypertrophy, nasal polyps, hoarseness of voice, macroglossia, narrowing of airway, and respiratory symptoms. And this is another story, an 11-year-old girl who came with polyphagia and weight loss. There is a clear deterioration in the school performance. She is inattentive. مامتها بتقول كانت شاطرة في المدرسة وبعدين بقت مش مركزة. She also has hyperactivity. اتشخصت إنها ADHD بس طلعت مش كده. She also has emotional instability and anxiety, irritability, restlessness, tremors, muscle weakness, and dyspnea. And the dyspnea was on exertion and at rest, as well as tachypnea. And the mother has Hashimoto thyroiditis. The girl is tall and her BMI is low. She's losing weight. She also has tachycardia, the heart rate 120 beats per minute. And if you look at the girl, she had diffuse goiter with exophthalmos. And look at her thyroid function. The TSH is very low, T3 and T4 very high. The thyroid antibodies and the TSH receptor antibody is very high. And the ultrasound confirmed diffusely enlarged thyroid and increased uptake by scan. So what's your diagnosis? Yes, this is Graves' disease, autoimmune thyroid hyperfunction. And if you look at this girl, the initial presentation was dyspnea and upper airway obstruction due to large goiter, which was causing pressure manifestation. Remember that hyperthyroidism triggers pulmonary hypertension and could lead to laryngeal obstruction. Now, this is the other side of the story. This is a 6-year-old boy who was born at home. He skipped neonatal screening for congenital hypothyroidism. The mother noted delayed motor and mental milestones and delayed speech. He is sleepy all the time. He has large protruded tongue, coarse, puffy, pale, with dry skin and non-pitting edema. He also has muscle weakness, hypotonia, severe dyspnea, and he was admitted to the ICU. His blood pressure and pulse are very low. His height is very short. The BMI is in the high normal and there is no goiter. At this point, because the boy had severe dyspnea, he was referred to the pediatric pulmonologist. الحقيقة الولد ده ما جالناش احنا الأول، ما راحش للإندوكرينولوجي، هو راح لحد chest condition, pulmonologist. Because the pulmonologist was clever, he did the T3, T4, TSH, and the TSH was high, T3 and T4 were low, the antibodies were negative, and this is the thyroid ultrasound. What's your diagnosis? This was primary congenital hypothyroidism. Unfortunately, it was a very late diagnosis لأن الولد ده كان حظه وحش skipped neonatal screening program وعشان كده ما تشخصش لغاية ما وصل بيه الموضوع إلى severe hypothyroidism. And pulmonary functions showed pulmonary hypoventilation, poor ventilatory response to hypoxia and hypercapnia. And you can see here pleural effusion, and this occurs with severe untreated hypothyroidism. So hypothyroidism can lead to respiratory symptoms if not treated in the form of pleural effusion, upper airway obstruction due to large tongue and large thyroid, obstructive sleep apnea, and hypoxia and hypercapnia. والحمد لله ما بقيناش نشوف المنظر الفظيع ده اللي هو الكريتينيزم، والكلام ده بسبب النيوناتال screening program which was developed in Egypt in 2000. يعني بقاله حوالي 26 سنة very well established في وزارة الصحة ومقترن بشهادة الميلاد، فالحمد لله ما بقيناش نشوف الكريتنز لأنهم بيتعالجوا في أول أسبوع من العمر. Now, this is an 8-year-old girl who presented with short stature, obesity. She developed carpopedal spasm, tingling, numbness, convulsions. And she also developed bronchospasm, stridor, and laryngospasm. She also has learning problems at school, and as you see in the photo, short, fourth, and fifth metacarpals. عندها skeletal manifestations, عندها tetany, convulsions, learning disorders, she's short and obese. So the urgent labs here, calcium, it came very low, phosphorus, very high, alkaline phosphatase is normal, parathyroid hormone is very high. What's your diagnosis? What do you think? Yes, thank you very much. This is pseudo-hypoparathyroidism type 1A, and she presented with stridor, laryngospasm, and bronchospasm, which is atypical presentation in such cases. The girl was treated with IV calcium and vitamin D, and please remember the respiratory and ENT manifestations of hypocalcemia. On top of the list, we have laryngospasm and bronchospasm. If you have persistent laryngospasm and bronchospasm, don't forget to measure serum calcium and phosphorus. On the other way around, hyperparathyroidism and hypercalcemia can lead to nodular calcifications in the lung, leading to dyspnea, dry cough, and restrictive functions of the lung, as you see in such cases. What about this boy? This is a 5-year-old boy presenting with obesity, weight gain, short stature, recurrent chest infections, and he had an attack of pulmonary embolism. He also has skin bruising, as you see in the photo, and easy fatigability, proximal myopathy and muscle weakness. He also developed psychosis and depression. There is no history of drug intake. As you see, the boy has moon face, acne, facial plethora. He was also found to be hypertensive. The blood pressure is above the 95th percentile, and the blood sugar is impaired. His thyroid function is normal, and if you look at the cortisol and ACTH, there is impaired circadian rhythm. And we confirmed the diagnosis by doing 24-hour urinary cortisol and dexamethasone suppression test. So this is what we found when we did CT on the adrenals. There was a mass in the right adrenal, and look how big the mass is. It turned out to be right adrenal carcinoma. leading to Cushing syndrome. And this boy presented with recurrent chest infections and resistant to treatment. Remember that excess cortisol dysregulates the immune system and causes abnormal findings in the lung, including inflammatory status. And in this algorithm, you can see the protocol that we follow in cases of Cushing syndrome. Most important is to exclude chest condition and screen for it. And this is a 13-year-old girl presenting with a normal birth weight, progressive weight gain, menstrual irregularities, interrupted sleep and breathing problems, obstructive sleep apnea. Her dad and maternal aunt are obese, and there is type 2 diabetes in paternal grandma. She's tall and she has abdominal obesity. The waist-hip ratio is high. She's in Tanner stage 2 to 3, and she was found to be hypertensive. The girl also has acanthosis nigricans. You can see in the photo in her neck, acanthosis nigricans. You can see here the labs that we did. Impaired fasting blood sugar, the hemoglobin A1C was in the diabetic range, the cholesterol, triglyceride, LDL are high, and the liver enzymes were found to be high. And this is a list of silent comorbidities. And then the girl developed sudden severe respiratory distress, and she was admitted to the ICU. So the diagnosis here is exogenous obesity, type 2 diabetes, dyslipidemia, hypertension, fatty liver, depression, and what we call obesity hypoventilation syndrome, which is a sudden hypoxia occurring in obese individual. And this is a very sad and dangerous story. فعلا ممكن تكون قنبلة موقوتة في الobese. And as you see, obesity through leptin resistance, mechanical overload, obstructive sleep apnea can lead to a state of hypoxia and hypercapnia, which can necessitate ICU admission in such patients. And you can see here the inflammatory and the immune dysregulation occurring in obese individuals, leading to obstructive sleep apnea and obstructive hypoventilation. And this is the final case, a 12-year-old boy born SGA with difficult feeding, weak suckling, severe respiratory distress at birth to the degree that the boy was ventilated. The boy was born floppy with hyperphagia starting at the age of 3 years, recurrent chest infection, and obstructive sleep apnea as well. The boy has some learning disabilities with short stature, obesity, small hands and feet. As you see in the photo, micropenis and small scrotum. The T4 is low, the TSH is low, so this is central hypothyroidism. And cortisol, ACTH were normal, and there is impaired fasting blood sugar. What's your diagnosis? حد قالها. Yes, thank you very much. جميل. This is Prader-Willi syndrome, and it was diagnosed by FISH. Would you like to start growth hormone immediately? إيه رأيكم؟ يلا على طول نبتدي growth hormone فيه؟ لا مش على طول. It is an FDA approved indication, but it's very important to do ENT evaluation, sleep study before starting growth hormone, because if you start immediately and the boy has sleep apnea, it could lead to adenoid hypertrophy and sudden death. So it's really important to refer to the ENT team to assess the child before starting growth hormone. And Prader-Willi syndrome is one of the congenital central hypoventilation syndrome. You can see throughout their life, neonate, infant, and child until adulthood, they have respiratory difficulties throughout life, including apnea in all phases of life. So I think the final conclusion to remember are, there are some key messages. Remember that ENT, pulmonary endocrine systems are interconnected. Endocrine disorders could present with respiratory and or ENT manifestations. Pulmonary ENT involvement in patients with endocrine pathology aggravates the disease prognosis, and it could be a cause of death. So it's really important to manage. Early diagnosis and treatment of respiratory ENT symptoms is important to save the life and improve the quality of life of children with endocrine disorders, because sometimes we need to buy the time. أحيانا بتبقى الحالة critical و urgent. We need to interfere very quickly to avoid trapping and to avoid falling when dealing with those really, really sensitive diagnoses. And I believe that working together is a must. We need to work as a team work. احنا الاندوكراين داخل في كل السيستمز اللي في الحياة simply لأن الهرمونز are going here and there in the blood. فاحنا ما نستغناش عن أي سيستم. وطبعا النهارده عشان خاطر الدكتور يوسف ما استغناش عن الاي ان تي النهارده. فحقيقي التيم ورك is really really important. Thank you very much for your attention.
Thank you. واحنا ما نستغناش عن حضرتك يا فندم خالص في الاندوكراين، والعالم كله ما يستغناش عن حضرتك.
ربنا يخليكي يا
شكرا
حبيبتي.
شكرا على